Module 6. Last Hours of Living. Overall message. Care in last hours is as important as at any other time in cancer care. Objectives. Prepare, support the patient, family, caregivers, assess, manage the pathophysiological changes of dying, pronounce a death and notify the family. Last hours of living. Everyone will die. Less than 10% suddenly. More than 90% after prolonged illness. Unique opportunities and risks. Little experience with death. Exaggerated sense of dying process. Preparing for the last hours of life. Time course unpredictable. Any setting that permits privacy, intimacy. Anticipate need for medications, equipment, supplies. Regularly review the plan of care. Preparing for the last hours of life. Caregivers. Awareness of patient choices. Knowledgeable, skilled, confident. Rapid response. Likely events, signs, symptoms of the dying process. Physiological changes during the dying process: increasing weakness, fatigue, cutaneous ischemia, decreasing appetite/fluid intake, cardiac, renal dysfunction, neurological dysfunction, pain, loss of ability to close eyes, weakness/fatigue, decreased ability to move, joint position fatigue, increased risk of pressure ulcers, increased need for care, activities of daily living, turning, movement, massage, decreasing appetite/food intake, fears, giving in, starvation, reminders, food may be nauseating, anorexia may be protective, risk of aspiration, clenched teeth express desires, control, help family find alternative ways to care, decreasing fluid intake, oral rehydrating fluids, fears, dehydration, thirst, remind families, caregivers, dehydration does not cause distress, dehydration may be protective, decreasing fluid intake, parenteral fluids may be harmful, fluid overload, breathlessness, cough, secretions, mucosa/conjunctiva care, cardiac, renal dysfunction, tachycardia, hypotension, peripheral cooling, cyanosis, mottling of skin, diminished urine output. Parenteral fluids will not reverse. Neurological dysfunction, decreasing level of consciousness, communication with the unconscious patient, terminal delirium, changes in respiration, loss of ability to swallow, sphincter control, to roads to death. Decreasing level of consciousness, the usual road to death, progression, eyelash reflex, communication with the unconscious patient. Distressing to family, awareness more than ability to respond, assume patient hears everything. Communication with the unconscious patient, create familiar environment, including conversations, assure patient of presence, safety, give permission to die, touch, terminal delirium, the difficult road to death, medical management, benzodiazepines, lorazepam, midazolam, neuroleptics, haloperidol, chlorpromazine, seizures, family needs support, education, changes in respiration, altered breathing patterns, diminishing tidal volume, apnea, Cheyne-Stokes respirations, accessory muscle use, last reflex breaths, changes in respiration, fears, suffocation, management, family support, oxygen may prolong dying process, breathlessness, loss of ability to swallow, loss of gag reflex, build-up of saliva, secretions, scopolamine to dry secretions, postural drainage, positioning, suctioning, loss of sphincter control, incontinence of urine, stool, family needs knowledge, support, cleaning, skincare, urinary catheters, absorbent pads, surfaces, pain in the last hours of life, fear of increased pain, assessment of the unconscious patient, persistent versus fleeting expression, grimace or physiologic signs, incident versus rest pain, distinction from terminal delirium, pain in the last hours of life, management when no urine output, stop routine dosing, infusions of morphine, breakthrough dosing is needed, PRN, least invasive route of administration, loss of ability to close eyes, loss of retroorbital fat pad, insufficient eyelid length, conjunctival exposure, increased risk of dryness, pain, maintain moisture, medications, limit to essential medications, choose less invasive route of administration, buccal mucosa or oral first, then consider rectal subcutaneous, intravenous rarely, intramuscular almost never, dying in institutions, home-like environment, permit privacy, intimacy, personal items, photos, continuity of care plans, avoid abrupt changes of settings, consider a specialized unit, signs that death has occurred, absence of heartbeat, respirations, pupils fixed, color turns to waxen pallor as blood settles, body temperature drops, signs that death has occurred, muscles, sphincters relax, release of stool, urine, eyes can remain open, jaw falls open, body fluids may trickle internally, what to do when death occurs, dawn, T call, 911, whom to call, no specific rules, rarely any need for coroner, organ donation, traditions, rites, rituals, moving the body, prepare the body, choice of funeral service providers, wrapping, moving the body, family presence, intolerance of closed body bags, pronouncing death, please come, entering the room, pronouncing, documenting, bereavement care, attendance at funeral, follow up to assess grief reactions, provide support assistance with practical matters, redeem insurance, will, financial obligations, estate closure. Summary. Care in last hours is as important as at any other time in cancer care.